Defy gravity. Reach for the skies. This is your life. Live it. Love it. Own it. Because we've got your back. Our passion for health. Our passion for science powers your passion for life. Hetero. For everyone, everywhere. 30 years of inspiring human belief in a healthier world. Passion feels great. It's your life. Unleash your dreams. Challenge every bend. Feel the rush. Run free. Break barriers. Blaze the trail. Come alive. Rise. Live the beat. Find your flow. Unite spirits. Power up together. Forge ahead. Conquer your limits. Be the force. Harness power. Defy gravity. Reach for the skies. This is your life. Live it. Love it. Own it. Because we've got your back. Our passion for health. Our passion for science powers your passion for life. Hetero. For everyone, everywhere. 30 years of inspiring human belief in a healthier world. Passion feels great. It's your life. Unleash your dreams. Challenge every bend. Feel the rush. Run free. Break barriers. Blaze the trail. Come alive. Rise. Live the beat. Find your flow. Unite spirits. Power up together. Forge ahead. Conquer your limits. Be the force. Harness power. Defy gravity. Reach for the skies. This is your life. Live it. Love it. Own it. Because we've got your back. Our passion for health. Our passion for science powers your passion for life. Hetero. For everyone, everywhere. 30 years of inspiring human belief in a healthier world. Passion feels great. It's your life. Unleash your dreams. Challenge every bend. Feel the rush. Run free. Break barriers. Blaze the trail. Come alive. Rise. Live the beat. Find your flow. Unite spirits. Power up together. Forge ahead. Conquer your limits. Be the force. Harness power. Defy gravity. Reach for the skies. This is your life. Live it. Love it. Own it. Because we've got your back. Our passion for health. Our passion for science powers your passion for life. Hetero. For everyone, everywhere. 30 years of inspiring human belief in a healthier world. Passion feels great. It's your life. Unleash your dreams. Challenge every bend. Feel the rush. Run free. Break barriers. Blaze the trail. Come alive. Rise. Live the beat. Find your flow. Unite spirits. Power up together. Forge ahead. Conquer your limits. Be the force. Harness power. Defy gravity. Reach for the skies. This is your life. Live it. Love it. Own it. Because we've got your back. Our passion for health. Our passion for science powers your passion for life. Hetero. For everyone, everywhere. 30 years of inspiring human belief in a healthier world. Passion feels great. It's your life. Unleash your dreams. Challenge every bend. Feel the rush. Run free. Break barriers. Blaze the trail. Come alive. Rise. Live the beat. Find your flow. Unite spirits. Power up together. Forge ahead. Conquer your limits. Be the force. Harness power. Defy gravity. Reach for the skies. This is your life. Live it. Love it. Own it. Because we've got your back. Our passion for health. Our passion for science powers your passion for life. Hetero. For everyone, everywhere. 30 years of inspiring human belief in a healthier world. Passion feels great. It's your life. Unleash your dreams. Challenge every bend. Feel the rush. Run free. Break barriers. Blaze the trail. Come alive. Rise. Live the beat.
Good afternoon, everyone. Today we are gathered here for our epic webinar series, Her Health, Her Future, the Mother's Metabolic Continuum. For the users I would like to give a guide for users who have joined from the desktop. You will have option to select the language. The webinar will be streamed in 3 languages: English, Spanish, and Russian. Kindly select the language which you wish to listen to. Simultaneously, for users who have joined from mobile, once you have logged in, kindly rotate your mobile phone and you will be able to select the language option: English, Spanish, and Russian, and select the desired language to view the session. Now, I hand it over to Dr. Someshwar from Hetero team.
Thank you, Ashmi. So, hi, good afternoon, our esteemed colleagues and doctors. Myself, Dr. Someshwar, Senior Manager at Medical Office for Emerging Markets for Hetero Labs Limited. And it's a privilege to welcome you all for today's session of the EPIC webinar series focused on endocrine practice, innovations, and clinical insights. So this series is proudly brought to you by Hetero, a global pharmaceutical leader serving communities across 145 plus countries with an established commercial presence. With 36 plus world-class manufacturing facilities and 6 R&D centers powered by over 2,000 plus scientists. We are dedicated to develop life-saving treatments for every health concern. As a we are the home of Asia's largest such complex for API manufacturing. Hetero remains committed to excellence in research, manufacturing, and marketing. So, with this, I ask tech team to play the Hetero corporate video. Yeah.
Mm.
we find it a fitting moment to reflect the lifelong health of a woman in our care. So our theme today is her health, her future, and the mother's metabolic continuum. So today's agenda is we have two sessions if anyone is missing for today's 2 p.m. and we also have at 8 p.m. IST. And the agenda as it shown, we have introduction, then we have with Professor Julia, she will be taking, and then we have a Q&A session. And there is a closing remarks. So can you move the slides? Yes. So, yes, can you move the slide? So in medical affairs, we often view metabolic disease through a static lens. So, but for a mother, health is a continuum. From the first metabolic stress test of a GDM in the reproductive years to the cardiovascular inflection point of menopause, a woman's risk profile is constantly evolving. So as we are moving away from being merely a glucose-centric to being outcome-driven, today we will explore a phase-wise strategy specifically designed to reduce the diabetes and the cardiorenal metabolic risk across every stage of a woman's life. So to lead us through this critical discussion, it is my distinct honor to introduce our esteemed speaker, Professor Julia Matter. And Professor Julia joins us from the Medical University of Graz in Austria, where she serves as a full-time professor of internal medicine. She is a world-renowned expert in diabetes, technology, and endocrinology. And she is holding a leadership roles within the EASD and the National Diabetes Guideline Committee. So the Professor Julia, the floor is yours to guide us through the details of the sex-specific differences in the type 2 diabetes and the mother's metabolic continuum. Yes. Over to you, Dr. Julia.
Thank you so much for the kind introduction and also for having me here as a speaker. And it's my great pleasure and honor to talk to you about a topic that's really close to my heart. Just trying to see if the slides are moving. No. Oh, yeah. Okay. These were my disclosures. And as all of us know, we have a very high prevalence of type 2 diabetes globally, and specifically in Southeast Asia and also in the MENA region itself, and also, of course, in South America. And that goes along with also the risk of obesity and the risk of also having other complications of diabetes in the course of the diabetes career. But it's not all the same. So there are sex-specific differences between men and women that are in many cases unrecognized and under-recognized in clinical routine. So for example, the adipose tissue distribution is in men predominantly visceral. In females, it's subcutaneous and only in the post-menopause moves to a more visceral distribution, which then might have a delayed, but in the end steeper risk of cardiovascular disease in the postmenopausal phase. Similarly, we do have a good insulin sensitivity in the premenopausal phase, but that again sharply declines in the postmenopause. So for CVD, we already talked about the increased risk at postmenopause, but it's not only that the risk is increased, but also that the symptoms might vary from females to males and might make it more difficult to recognize the symptoms of cardiovascular disease in females compared to men, because many of our textbooks specifically focus on on male patients and leave out the female counterparts. We also see that there is a faster decline in the kidney after 60 years of age. We also see that the protective effect of estrogen is only there until the menopause. So all of that contribute to a significant risk increase over time in women when they reach postmenopausal stages. So, What again do we see? We see differences when it comes to complications, when it comes to cardiovascular mortality in the postmenopausal phase, as said before. We do see that depression and anxiety increase in women. We also see that the complications, of course, can affect the microvascular system, meaning increased pain, neuropathic pain, and nerve injury. The only difference where potentially males might have a higher risk when it comes to microvascular complications is still diabetic foot disease and amputations. Interestingly, for whatever reason, we seem to overlook not only the complications or the existence of the complications themselves, but also seem to treat, in many cases, women less aggressively as we do for men. Specifically, in many studies, men are also more represented. However, we are quite good in achieving treatment goals in females in the routine care in many cases. So specifically, there is seemingly a high demand in meeting the expectations of kind of the global aspect of health, so that a lot of women nowadays ask for support when it comes to weight reduction therapies. So why does sex matter? So as said before, estrogen levels are protective in females. They help to contribute to insulin sensitivity. They have an impact on fat distribution. So in the premenopausal phase, subcutaneous, versus in the postmenopausal phase, more visceral and seemingly comparable to men. Premenopausal women also have a higher skeletal muscle and hepatic insulin sensitivity, and with that leading to reduced glucose levels and also better glycemic control. In women with type 2 diabetes, there is a higher relative risk, however, of cardiovascular disease. And not only the risk is higher, but it's often also underdiagnosed and untreated. When we then have a look at the reproductive lifespan from a cardiometabolic risk perspective, we do see, of course, in the reproductive risk phase, there might be a risk of gestational diabetes with a low risk of cardiovascular disease, but high risk of gestational diabetes risk. In the perimenopausal phase, the lipid parameters might change with an increase in triglycerides and also an increase in blood pressure. We again changing the cardiovascular risk and increasing the cardiovascular risk. In the early menopause, we also see an influence on the visceral fat distribution and on insulin resistance, leading to higher HbA1c levels. And at the age of 60 plus in the late menopause, we see an increased risk in females of chronic kidney disease, heart failure, and frailty. And the kidney disease comes along with a reduction in eGFR. So when we talk about the early stages of changes or differences between females and males, we do see, of course, differences in gestational diabetes across the different regions. So we have specifically high risk of gestational diabetes in the MENA region and also in Southeast Asia. And if people from these regions migrate to other countries, of course, we again see in our migration population in Austria higher risk of diabetes in people originating from these countries in comparison to the native European population, where the risk is only at around 8%. And gestational diabetes is more or less a silent marker of a potential risk of diabetes over the lifespan. So people or women who have had gestational diabetes have a higher risk, tenfold higher risk to develop type 2 diabetes compared to those without gestational diabetes. 50% would develop that already within the next 5 to 10 years. So it's not a very long time frame. Until then, there is also a 20% risk of having gestational diabetes in a subsequent pregnancy. and the women who were affected by gestational diabetes compared to women without gestational diabetes. It's quite a comparable cascade to the regular form of type 2 diabetes, so that we have stress to the beta cells. In the postpartum phase, we have an increased insulin resistance that persists. Then prediabetes develops, open type 2 diabetes develops, and with type 2 diabetes, the complications such as cardiovascular disease and chronic kidney disease can start to develop. There is, again, a weight gain in relation to BMI. So if women have a weight gain of over 18 kilograms, there is a higher risk of also developing macrosomia in the unborn child. And in those women, we should specifically have a look for type 2 diabetes following pregnancy and do postpartum screening. So beta cells can be exhausted over time, also in the postpartum phase. The placental hormones are the driver of physiological insulin resistance in the third trimester, and that is normally compensated by beta cell mass. But in gestational diabetes, beta cells cannot compensate for that. So there is potentially in the postpartum phase incomplete recovery of the beta cells, and they only are at about 40% of their capacity as they were before. That then can result in a type 2 diabetes development. It also seems that there is an epigenetic programming so that gestational diabetes can alter the DNA methylation in the unborn child and also generate intergenerational metabolic risk. And that's why we need to be specifically careful in those children born to mothers with gestational diabetes. So that's why it's important to really take good care of our women throughout the pregnancy, specifically in those at risk of developing gestational diabetes or type 2 diabetes. In those who already have type 2 diabetes, they should be taken care of in a good manner, similarly to our women with type 1 diabetes. So we should already start in the pre-pregnancy care so that the mothers conceive in good glycemic control so that they don't have problems already upfront. There will be recommended for having lifestyle recommendations so that they should not take in too much carbohydrates with a too high carbohydrate load. So they should also take in lower amount of saturated fat and increase fiber intake instead. They should still exercise, so low to moderate intensity in at least the majority of the days in the week. They should avoid excessive weight gain. And it's really important also to have a look what other parameters need to be supplemented. So especially in the first trimester, folic acid to have a good development of the central nervous system. When it comes to therapy, we can consider, of course, metformin, which is very safe in pregnancy. However, what we do not know so far, what is the long-term effect in the offspring. We should also take good care of the blood pressure and we use medication that and then, of course, in case of therapy requirements with insulin, we should avoid severe hypoglycemia. We should screen for retinopathy and nephropathy, and also avoid excursions to the other end when it comes to hyperglycemia. And not only pre and pregnancy care are required, but also postpartum care, especially in those who have a higher risk to develop late complications. So we know that in early pregnancy, type 2 diabetes risk is in early pregnancy, if women are not well controlled, there is a risk of diabetic retinopathy, and the prevalence of new onset can be up to 9%. So that's why we should really have an ophthalmological assessment, not only when pregnancy is there, but already before conception takes place. And then during the first trimester, maybe also during second and third trimester, and in the first year postpartum to see if changes have occurred. Normally, in a normal pregnancy, we would not expect that the kidney function declines. But of course, if there is preeclampsia or preterm delivery, that can affect also our kidney function. So that's why also the American Diabetes Association recommends the screening for nephropathy in each of the trimesters. But we also see that in the postpartum phase, if mothers are breastfeeding, that can help excessive weight that was gained. But not only that, we should also suggest those mothers to keep up with the lifestyle interventions that were suggested and also to follow structured exercise, knowing that, of course, the mom of a young child might be really challenged and might not have enough sleep and so on. So if we put too much burden and pressure to her, that might be sometimes also frustrating, but at least try to recommend moderate exercise. So when we then look at a cohort study where roughly 300 mother-child pairs were observed for a period of 2 years, it was seen that at least nearly 1/4 of the mothers still had excess body weight at the 2 years mark. But those who were breastfeeding longer than 2 months had a reduced risk of excess body weight compared to those who were breastfeeding only for 2 months or below. So breastfeeding seems to be protective of body weight and reduce body weight again in the postpartum phase. We have shortly discussed about metformin, which is a metabolic stabilizer, as we can say. So it can help us to generally reduce type 2 diabetes risk of roughly 1/3%. It can also reduce the type 2 diabetes risk in women who had gestational diabetes, and as a monotherapy can reduce HbA1c of up to 0.9%. Why is it working like that? It helps us to increase the peripheral glucose uptake via GLUT4 upregulation, reduces the intestinal glucose absorption, seems to affect the gut microbiome and increase the GLP-1 secretion, has anti-inflammatory effects, and seems to be at least weight neutral to maybe helping us to reduce body weight again of about 1 to 2 kilograms. When we then look at other medications, so namely, for example, DPP-4 inhibitors, when we look into their glycemic durability, what effects do they have? So after metformin, that could be a very good medication also in young women. We see an increase in GLP and GIP levels with an increase in endogenous insulin production and a reduction in glucagon production. We see HbA1c reductions. We see cardiovascular safety for sitagliptin in the TECOS trial. So it was non-inferior to other medication, and it might be renal those who have a GFR of below 45. On the other hand side, vildagliptin is again a dual DPP-4 inhibitor with greater active GLP-1 exposure. It manages to reduce HbA1c quite in a similar way by -0.7 to 1%. It's again weight neutral, has less hypoglycemia compared to sulfonylurea, and in a trial where it was looked for cardiovascular safety, we have shown in the Gallant trial that it's cardiovascular safe in especially high-risk elderly populations. The postprandial control is superior to other oral agents. When we then look at the menopause and compare again females to men, the women are depicted in red and the men in blue. We see that in the postmenopause, so at age 55, there is a steep increase in the cardiovascular disease risk. There is an increase in LDL cholesterol after estrogen is not produced in sufficient manner again. We see a rise in visceral adiposity during perimenopause, and there is more heart failure in postmenopausal women compared to the premenopausal phase. So, and the set point here is roughly ages 50 to 52. So what happens actually in menopause? So we have less estrogens. We have, in many cases, a reduced energy expenditure. There might be, due to the visceral fat, more inflammation, dyslipidemia, and they then together again disturb the endothelial dysfunction or endothelial function, and that can result in hypertension. The inflammation, on the other hand side, has an impact on oxidative stress, and both of that can then be influenced again by insulin resistance. And kind of that vicious circle that we have here in the postmenopausal phase and menopausal phase can increase the cardiometabolic risk. With the increased BMI, increased waist circumference, reduced lean body mass, and increased insulin resistance, we might see an unfavorable lipid profile. We might observe hypertension and again having an increased cardiovascular risk, leading to atherosclerosis, cardiovascular disease, and myocardial infarctions. So, is there a risk of cardiovascular event with or without hormonal replacement therapy? So we do see that there is, in people with hormonal replacement therapy, a reduced risk of ischemic stroke or stroke. So potentially there might be some beneficial effects here. Again, looking into visceral adiposity, which is for sure one of the main drivers of the cardiometabolic and cardiorenal metabolic risk in women, we see alongside the visceral adiposity an increase in atherosclerosis, free fatty acids, lipotoxicity, chronic inflammation, reduced kidney function, increased insulin resistance, also an activation of the RAS system, leading to high blood pressure. And failure and kidney function, we want to focus on cardiorenal protection early. That's why the mechanisms are so important. So that's why, for example, SGLT2 inhibitors and GLP-1 receptor agonists should be prioritized, especially in those at risk of developing complications. We should go for goal-directed medical therapy. The choice of drug should be evidence-based and also based on cardiovascular outcomes. And weight loss is for sure also a main goal, as weight gain has very negative effects, as we had discussed before. So now it's moving again. When we look into the semaglutide results, and that is from the SUSTAIN trial, we do see that we have improved body weight loss with semaglutide over GLP-1 over DPP-4 inhibitors, or also over insulins, of course. So whenever the body weight is affected and should be targeted, glutide, for example, or also other GLP-1 receptor agonists have a benefit over other medication that simply only help us to reduce the glucose values. It's moving a little bit slower now. No, not sure if I do this. Yeah, I still have the control. But not only body weight is reduced in these participants, but also we see, especially, for example, in SUSTAIN 6 trial, that there is a cardiovascular benefit in people with type 2 diabetes and high cardiovascular risk. So semaglutide contributes to a 26% lower risk of the primary composite outcome, which was cardiovascular causes, non-fatal myocardial infarction, or non-fatal stroke. And that lower risk was driven by a roughly 40% decrease in non-fatal stroke, 26% decrease in non-fatal myocardial infarction, but there was no difference in, or no significant difference in cardiovascular death. When we look into the weight loss and looking weight, roughly a 5 kilogram average weight reduction compared to baseline. In SUSTAIN 8, we have nearly 6 kilograms compared to canagliflozin, and we have also a visceral fat reduction more than subcutaneous fat reduction. What could be the female-specific benefits? So we have a higher percentage body weight loss in females. We also have an improvement in the adipokine profiles. We have a blood pressure reduction and also an improvement in the lipid panel, namely a 3% reduction in LDL cholesterol and an 80% reduction in triglycerides. When we then look into people with heart failure, and that is again a STEP HFpF study, we see that females had a good participation in the trial. So there were roughly over half of the participants female. The age was 70 years. It was largely a Hispanic population also included, but the majority, as in many of those trials, was white, black Americans. What we had observed was rates that were reduced. We had seen a reduction in body weight, a reduction in BMI, an improvement in blood pressure control. Also the levels of parameters for heart failure reduced, and the CRP was also reduced over time. And at week 52 specifically, we had seen a mean change of 60 points when it comes to KCCQ CSSS, which is also important in females. So again, when we look into the changes, females versus men, there was higher changes observed in body weight, and the treatment ratio was comparable between men and female. When it comes to adverse effects, especially nausea, that were consistently higher rates reported in females compared to men. So we had that for tirzepatide in the pooled analysis, that they reported nearly double the rates of nausea compared to males. And that existed throughout the different doses of tirzepatide. When it then comes to vomiting, also again, we had higher rates in females compared to males when it comes to tirzepatide, but also we already had that in the placebo group. So potentially the women were in generally a little bit more affected by side effects of the gastrointestinal tract. Now I shortly want to look with you into a perimenopausal woman. And so she is 48 years of age, has type 2 diabetes since roughly 6 years and is in the perimenopause. BMI is 31.2 kilograms per meter square with central obesity. HbA1c is 8.4% on metformin twice a day and glimepiride 2 milligrams. Blood pressure is slightly above target, and triglycerides are 2.8 millimoles per liter. LDL is not reported, and HDL is 0.9 millimoles per liter. She has stable kidney function with a GFR of 72, and no known cardiovascular risk. So what do we see? We see elevated triglycerides, borderline microalbuminuria in the urine. We see an increased fasting glucose, mild NAFLD existing already, a slightly elevated CRP, and her waist circumference is also increased. So what was then the management decision that was taken? She was taken to semaglutide, and it was increased and titrated to 1 milligrams after 4 weeks. Glimepiride was stopped, specifically also because of the risk of weight gain and hypoglycemia. Metformin was continued, and body weight target was set to reduction of -5%. HbA1c goal was set to 7%, with the hope that also the microalbuminuria would again normalize, and a six-month follow-up was scheduled to see how cardiovascular risk has evolved. And of course, also the side effects were decided to be monitored. Importantly, medication that has also quite good safety profile and has not any other relevant side effects, but also potentially a contributing effect on body weight loss, should be kept in comparison to the therapy alone. So what else can we talk about? So when we think of the gliflozins, who have, of course, very positive and effects when it comes to cardiovascular risk reduction and heart failure reduction. How can we have a look here from the female side of it? Because the dominant heart failure phenotype in females is heart failure with preserved ejection function, with an ejection fraction of above 50%. And only a smaller amount is contributed by reduced ejection fraction heart failure. So what can we see in our female patients? So especially in women who have hypertension, obesity, and are aging, there seems to be a higher risk to develop heart failure with preserved ejection fraction. We can see that dapagliflozin reduces the preload, the afterload, inflammation and fibrosis phase. So currently, we can for sure say that medication that reduces cardiovascular risk, obesity in females with postmenopausal development should be considered. So there are pleiotropic mechanisms of LTT that go beyond glycemic control. So we see, of course, the glucouric effect with reduction of HbA1c of roughly 0.8 to 1%, which leads also to a slight caloric deficit, leading to weight loss of 2 to 4 kilograms over the course of treatment. We have an increased natriuresis and an improvement of the hemodynamic situation, reducing preload, reducing blood pressure by 3 to 5 millimeters mercury for the systolic blood pressure, and also a reduction of the cardiac wall stress. We potentially see an slight increase in ketone body production that might be an alternate fuel, a superfuel for the myocardium, with again might be a cardioprotective factor in the care of people with type 2 diabetes. Then we see an increase in the EGFR, potentially to tubuloglomerular feedback restoration, and we see a slower decline of the EGFR over time. There seems to be anti-inflammatory and antifibrotic effects as well, with a reduction in the epicardial fat volume and cardiofibrosis markers, and also a beneficial effect when it comes to EPO release, increasing also hematocrit and helping to have an improved oxygen delivery to the myocardium. So there is the cardiorenal metabolic nexus, where we have, of course, the risk of women that is disproportionately high for heart failure with preserved ejection fraction and chronic kidney disease. And on the other hand side, we have also the risk of metabolic disease overlapping with kidney disease. And there might be some criteria for women needed to define stages 1 to 4 of the American Heart Association. So it's not moving again. Shall we now have changes and suggestions in diabetes medication? So what should we consider? Of course, the goal is not only to reduce glucose control and to reduce glucose and improve glucose control, but also really to have a good cardiovascular and kidney benefits. So in people with high cardiovascular risk and people with high indicators of cardiovascular risk, we for sure should prioritize on GLP-1 receptor agonists with proven cardiovascular benefits, or SGLT2 inhibitors with proven cardiovascular benefits. In people who already have heart failure, SGLT2 inhibitors should be prioritized. Similarly, in people with chronic kidney disease. When it comes to weight gain, of course, weight management is the essential driver, and we should focus on medication with high or very high effect on body weight, which would be semaglutide or tirzepatide. Same goes for dulaglutide and liraglutide, who have high effects, and if not available, on intermediate medication that has maybe not as a strong effect on body weight if other medications are not available or cannot be afforded. So that is, of course, something true both for females and males, but we should really prioritize the underlying conditions in the respective individuals. So again, in the aging person, in the aging matriarch, as we can say, we do not only have the risk of glucose control and overweight, but on the other hand side, we should be very careful about frailty that can develop, chronic kidney disease that can develop, and of course, should be very, very careful when it comes to glucose lowering effects, that we do not cause hypoglycemia. Because roughly 60% of women over 70 years of age have chronic kidney disease stage more than 3 or higher than 3. They have a higher fall risk, especially when it comes alongside medication that can cause hypoglycemia. They have a higher decline in their EGFR at the age of 65 and beyond. And the risk of hospitalization for heart failure versus age-matched men is twofold. So if we have a woman, same age, same comorbidities as the men, the risk of hospitalizing them for heart failure might be double. So what is the therapeutic approach here? We should avoid hypoglycemia. So when it comes to medication, we should look for a safe medication that can avoid hypoglycemia, namely, for example, DPP-4 inhibitors, metformin, SGLT2 inhibitors. When it comes again in combination with high body weight, GLP-1 receptor agonists might be useful. However, we might be a bit wary when it comes to older age. that sarcopenia can be a problem, and we might need to look for medication that is fat neutral, does not help us to reduce any more body weight. And at some point in time, it might be even necessary to start insulin in aging people, simply to maintain glucose control, but also to avoid a weight loss or weight or loss of lean body mass. So we need to be very careful in the selecting of medication. We should have a simple regimen, but should also look into cardiovascular benefits and avoiding complications at the same time. And as we also discussed that kidney function declines even more steeply compared to men, we should have a selection of the drugs based on the eGFR. So metformin might need to be stopped. Also sulfonylureas should be avoided in that case. And a very safe bet in that situation would be linagliptin, where no dose adjustment is needed. And those drugs would also not reduce body weight too much. Trying to move the slides again. So what have we learned from the past, especially when it comes to higher age populations and high-risk patients? So there were already back 5 to 6 years the Carmelina and the Carolina trials, where they looked into linagliptin in type 2 diabetes. In Carmelina, type 2 diabetes with high cardiovascular and kidney risk, roughly 7,000 participants that were followed up for 2.2 years. So that was non-inferior to other therapy. The heart failure risk was also non-significantly different, also safe in chronic kidney disease. No dose adjustment was required, irrespective of the kidney function. And compared to sulfonylurea, there was lower risk of hypoglycemia. For Carolina trial, these were again 6,000 people comparing linagliptin versus glimepiride, followed for 6 years. So that's the longest ever DPP-4 inhibitor trial. It was non-inferior to sulfonylurea when it comes to MACE. It has a significant risk reduction when it comes to severe hypoglycemia, namely 81% less risk. The body weight was more or less comparable between the groups. And it was a pragmatic comparator trial, especially when we look into the female subgroup. The safety profile was comparable, so no extraordinary findings to be seen. And so potentially DPP-4 should be the first medication of choice compared to sulfonylureas. When it comes to SGLT2 inhibitors, again, several trials have been done, and we see that the kidney function stays more stable in people who are exposed to SGLT2 inhibitors compared to those who are treated with other medication. When we then look specifically at the female subgroup, the renal protection is also consistent in that group, especially when we consider that after years 60 and beyond, there is a post-menopausal steeper decline normally in kidney function to be observed, but that could be halted in that treatment group. So what differences in medication do we have? So metformin has a greater HbA1c reduction in men compared to women. However, a greater body weight reduction effect in females compared to men. In general, it seems that women are a bit less adherent to that therapy compared to men. The side effects like gastrointestinal symptoms seem to be slightly elevated in women. Maybe that's also comparable to what we have observed from the GLP-1 receptor trials, where already at baseline there were higher rates reported. When it comes to sulfonylurea, there is seemingly a higher effect in men when it comes to HbA1c reduction, but the hypoglycemia risk is comparable between the two. When it comes to thiazolidinol needs, the glucose metabolism in women with obesity seems to have a greater effect on glucose control. So we have greater HbA1c reductions as compared to sulfonylurea. the adverse effects, there might be a higher risk of weight gain in females and also a higher risk of edema development, higher risk of bone fractures, and also higher mortality rates, specifically under therapy with rosiglitazones. So nowadays, potentially, except for very severe cases of insulin resistance, not our treatment of choice anymore. When it comes to SGLT2 inhibitors, there is a seemingly small trend for better glycemic control in males over females, but cardiovascular benefits, hospitalization rates due to heart failure, and changes in nephropathy are comparable. Unfortunately, in many countries, women see a lower prescription rate. Some side effects might be higher, especially when it comes to the risk of urogenital infection or urinary tract infections, higher urosepsis rates, slightly higher rates of fractures and ketoacidosis. For GLP-1 and GLP-1 receptor agonists in combination, greater weight reduction effects in females compared to men. The majority of trials, we see no difference between the sexes when it comes to HbA1c reduction. The outcomes for MACE are comparable between the two. However, women, as said before, have a slightly higher rate of gastrointestinal complications. So what hypotheses exist regarding these observed differences? First of all, there might be already some anatomical differences at baseline between males and females, and also then pregnant females when it comes to body weight, to size, to body surface, also to body water. So in general, females have a lower amount of total body water, except for pregnant females. There seems to be differences in extracellular water. And so what could be kind of the reasons for the sex differences when it comes to adverse event reporting? So in many cases, also when it comes to body weight, women might be more often overdosed. If we think of the smaller distribution volume that is available, the free fraction of drug is larger, the clearance from the body seems to be slower. Women are sometimes more sensitive, as it seems, to some pharmacodynamics. So there might be some alterations in the receptor number, in the receptor binding, and in the signal transduction pathways. And women might take a larger amount of different medications with the effect of larger drug interaction capacity that could then again alter the pharmacokinetics and pharmacodynamics. Other factors, of course, symptoms sometimes are different. So thinking again of the difference in how myocardial infarction can present. In many trials, especially in the past, women were underrepresented. And so the symptom knowledge in many cases is linked to males. Females have more subcutaneous fat tissue that could be a factor. Women tend to be a little bit more interested in lifestyle changes, and nutrition are also in many countries seen to be the ones making healthier food selections and wanting to have their body weight under control more often. However, on the other hand side, men do more sports in many countries, especially when it comes to strength training, but still men are more prone to sarcopenia, even if they try to avoid. So when we think of the algorithm for treatment, what should we consider? Early years with diabetes or gestational diabetes that just has passed, metformin and sitagliptin. Later stages, perimenopause, metformin, vildagliptin, and semaglutide. Here we see a good achievement of HbA1c, glucose control, reduction in body weight, reduction in blood pressure, and also aiming for better lipid control. In the post-menopause, we need to avoid cardiovascular disease. We want to avoid the occurrence of heart failure, and we need to start cardiorenal protection in that sense. In the aging person, in the matriarch, as we can call her, we should avoid hypoglycemia, we should have a frailty-safe regimen, and we should maintain the GFR in a stable manner. So the therapy should be escalated female lifespan. It should not only focus on HbA1c, and the transition is really an opportunity to really prevent organ damage depending on the stage the woman is in. So the takeaways that I brought together for you: there are differences between females and males. There are sex-specific trajectories that demand specific therapeutic regimens, not only a one-size-fits-all approach and only not HbA1c driven. Gestational diabetes is the first metabolic stress test, and it can increase the type 2 diabetes risk by 10-fold. So afterward, the postpartum phase, we should start for screening for type 2 diabetes. We should initiate therapy to close the gap to develop type 2 diabetes. The midlife is the inflection point where the menopause is the driver of visceral adiposity, insulin resistance, and also an increased risk already of heart failure. So here we should have the start of GLP-1 receptor agonists and SGLT2 inhibitors in a timely manner. The aging matriarch, on the other hand side, needs protection, not only glucose control. So we should have a medication that helps us to maintain muscle mass, to avoid hypoglycemia, and requires to have a non-adjustment for the kidney function. So the right drug in the right phase for the right person or the right woman is really a good foundation for precision care, and we should really make our therapy choices based on the life cycle the woman is currently in. Thank you very much.
Yeah. Thank you, Professor Julia, for that wonderful masterclass in precision care for mother's metabolic continuum. As now we are moving to our interacting session with the poll questions. And please take a moment to send your responses as they appear on your screen. I also encourage everyone to engage with our speaker by posting your questions in the Q&A section or the comment box on your right-hand side. And we also want this to be a dynamic exchange of the clinical insights. So now I request our tech team to please release the poll to the audience. So we have a first question that is on GDM. A woman with a history of gestational diabetes has approximately how much higher risk of developing type 2 diabetes compared to women without GDM? It is 2 times higher, or 5 times higher, or 10 times higher, or not significantly elevated. Okay, so you can give the answer in the poll session. Yeah, so can you move to the second question? Yeah, so we have a second question on the phase-wise cardiorenal metabolic algorithm. Which drug combination is recommended for a post-menopausal woman with age of 50 to 65 years with type 2 diabetes? Is it metformin sitagliptin or linagliptin with empagliflozin, or semaglutide plus dapagliflozin, or metformin and vildagliptin with triple combination? Yeah. So next. So we have a third question. Why is the linagliptin particularly advantageous for an elderly diabetic woman with a chronic kidney disease? Is it because of significantly lower HbA1c more than any other DPP-4 inhibitor, or it requires no dose adjustment regardless of eGFR level, or it causes the greatest weight loss among the oral anti-diabetic drugs, or it reduces the risk of hypoglycemia with independent of glucose? Okay, the fourth question. So fourth question is regarding any sex-specific differences in GLP-1 receptor agonists like semaglutide and tirzepatide. Which of the following statements is most accurate? First, men achieve greater percent weight loss than women. The second option is women experience greater weight reduction, but also a higher risk of gastrointestinal side effects. Okay, and the third, both sexes experience identical rate, and D is the MACE outcomes are significantly different. So you can give the answers in the poll section. I think we have one more question. So under the new 2025 and 24 paradigm for diabetes care, what has replaced HbA1c as a primary therapeutic target? Is it fasting glucose less than 100 mg per deciliter, or is it because of MACE prevention, HHF reduction, and EGFR preservation, specifically focusing on cardiorenal outcomes, or is the therapeutic target is body weight reduction at least 10%, or blood pressure below 120 by 80? So you can give your answers in the poll section. Okay. So now I also encourage everyone to post your questions in the Q&A section or the comment box. Then we have questions. Yeah. So tech team, can you show the poll on the screen?
It is in the chat window.
Okay. I think for the first question, where we have women with GDM, how much is the risk of developing type 2 diabetes compared to women without GDM? So almost more than 66% of people have said that it is more than 10 times. And for the second question, a phase-wise cardiorenal metabolic algorithm, where what is the combination is recommended for a postmenopausal woman with type 2 diabetes? It's the majority of the audience has replied that semaglutide plus dapagliflozin. And for linagliptin, particularly advantageous in elderly diabetic women with CKD, majority are answered that it requires no dose adjustment regardless of EGFR level. Yes. And regarding the fourth question, specific sex differences in GLP-1 receptors. So majority of the people said that women experience greater weight reduction, but also a high risk of gastrointestinal side effects. And for the fifth question, I think the majority of the answer came for the MACE prevention, that is cardiorenal outcomes, was the primary therapeutic target for new guideline diabetic care. Yes. So can I see any questions from the audience? Yeah. And Professor Julia, we have a first question. That is, since waist circumference is a better risk predictor than BMI in women, what cutoff values do you recommend for a clinical intervention in postmenopause?
Yeah, so it depends a little bit on the region of the. Can you hear me?
Yeah, we can hear you.
Yeah, you can hear me. It depends a bit on the region. And we should, of course, see that we can reduce not only the say again the question.
So since waist circumference is a better risk predictor than BMI in women, what are the cutoff values do you recommend for a clinical intervention in postmenopause?
So if we can reduce it to below 90, should be at least kind of our target. If we can reduce it below 85, that would be kind of a good cutoff value, and below 80 should be our target value. But again, a little bit depending on the region of the world, so might be different for Southeast Asians compared to Europeans compared to Americans from the continent.
Yeah. Thank you, Dr. Julia. As you
Do we
correctly
have any
mentioned,
more?
it varies from
Sure.
population to population. Yeah. So,
Do we have any more?
questions? Let's see.
I don't see questions, so that.
I think, yeah, we don't have any more questions. Tech team, any questions?
But of
Yeah.
course, if there are
So, yeah,
more
no
questions coming up,
yeah,
they can send me an email and I would answer to that as well, or send you an
sure,
email and you
sure,
can forward.
Professor. Yeah. So, thank you, Professor Julia, for that masterclass in precision care and for sharing your valuable expertise with us today. As we conclude, the takeaway is clear. The women are biologically different. Their risk trajectory demand a strategy that is as dynamic as their lives. Whether it is managing risk of type 2 diabetes following GDM or protecting the aging from a heart failure or CKD, our choice of therapy from foundational metformin or to advanced SGLT or GLP receptor agonist must be precise. On behalf of Hetero, I want to thank you, all of you, for your commitment to improving the women's health. Please remember to scan your QR code provided on your to provide your valuable feedback. So, additionally, you can also download your participation certificate directly from the platform after the session concludes. Thank you. Have a wonderful evening. Yes. Yeah. Thank you, Professor.
Thank you. Was the audio?
Passion feels great. It's your life. Unleash your dreams. Challenge every bend. Feel the rush. Run free. Break barriers. Blaze the trail. Come alive. Rise. Live the beat. Find your flow. Unite spirits. Power up together. Forge ahead. Conquer your limits. Be the force. Harness power. Defy gravity. Reach for the skies. This is your life. Live it. Love it. Own it. Because we've got your back. Our passion for health. Our passion for science powers your passion for life. Hetero. For everyone, everywhere. 30 years of inspiring human belief in a healthier world.